what, pick whichever one you want to talk about, but what did you get from those two studies?
Yeah, I think I agree. TCT was very exciting. It actually felt like a throwback TCT with a lot of coronary studies. Coronary stuff was, foregrounded, and the structural thing was on the last day. So I think, TCT was exciting from that perspective. I participated in Shortcut, so we can talk about that. We first, if you like, we recruited at both of the institutions I was at. Shortcut is investigator-initiated at the BAME Institute. Suzanne Barron and Bobby A were the co-PIs. It's basically a head-to-head comparison of cutting balloon versus IVL for de novo severely calcified lesions. It's around a 400-patient study. And so again, to put it into context, Eclipse was around 2,000 patients, which was really focused on clinical outcomes. For Shortcut, the primary outcome was MSA. So it's an imaging-focused endpoint. They did do clinical follow-up up to 30 days, but really the focus is on, the imaging result that you get, the MSA. So that's why you can have a 400-patient trial, because it's powered for these imaging endpoints rather than clinical endpoints. And then and as you said, it's not published yet. So we just have, the presentation that Suzanne did at TCT. But the important thing for people to know is that there were two kind of strata to the trial. So there was an atherectomy cohort and a non-atherectomy cohort. And patients were randomized within each cohort. So it's almost like, two trials within one. So there's an atherectomy group where you get atherectomy at baseline, and then you get randomized to cutting balloon or IVL. And then you get a non-atherectomy cohort where the kind of primary calcium modification is one of those two devices, so cutting balloon or IVL, and you're randomized 1-to-1. So you end up getting these kind of 4 cohorts, but the overall, the primary endpoint was for the whole group together. Atherectomy, non-atherectomy is just overall looking at IVL versus cutting balloon. And there was no significant difference in MSA between the two groups, overall cutting balloon and lithotripsy. But if you then pass it out into the atherectomy cohort and the non-atherectomy cohort, the atherectomy cohort had no difference. And so if you got rotational atherectomy at baseline, the final MSA was the same with IVL and cutting balloon. But if you didn't, and it was in the non-atherectomy cohort, there was a significant difference, and non-inferiority was not met. And numerically, the MSA difference was actually quite large. It's over 1 millimeter. And so, I think that all of us would agree that a millimeter difference in MSA is likely to predict long-term outcomes. Again, we can't tell from this trial because it's 30-day follow-up only. And the number of patients is too small for that too. But yeah, if you look at that non-atherectomy cohort, there was not non-inferiority met there. Actually, Antonio Colombo did the kind of commentary after the TCT, and I remember the way he described it was, I think he said atherectomy is the great equalizer. And so yes, if you're going to do atherectomy up front, then you can get a very good result in these, in these lesions that were included with cutting balloon therapy, whether that is, to your point earlier, going to be reproducible, teachable, applicable, that we're going to have to get people to do rotational atherectomy, then use the cutting balloon to size it appropriately. Again, imaging mandated in this trial, which is, I think, a strength. Size it appropriately and then inflate it to high atmospheres of pressure. But, you can tell me from your conversations with your colleagues whether that is, after they were looking at the COPS trial, whether that's going to be necessarily something that can be easily replicable.
Yeah, when I have these different jobs that I do, and they force me to have 3 levels, at least that I can see at the moment, 3 levels of how I evaluate things. I have this one hat that I wear that has me look at things from a market perspective, a larger sort of big bucket of therapeutics and the way that the field is going. I have the second hat where I'm, director of a group, and I look at, what do we do at my hospital? Like, how do I lead this group in terms of novel information and device utilization? And then I have my personal hat, right, where it's just me in the cath lab taking care of people. And so I have these 3 sort of, and they're very overlapping Venn diagrams, right? So when I think of my first hat and I look at it just from a larger market, perspective, I think, well, here's the problem. Nobody uses atherectomy. We spent decades trying to teach people to use it. No one's going to use it. So how is that going to affect clinical practice on the larger scale? I don't know. I guess I'm a little dubious because I just don't know how to get people to use atherectomy. And frankly, I'm a little, I just don't see it happening. And that's not a comment on anything other than that's just the way interventionalists seem to be, whether that's good, bad, it just seems to be. Then I have the director of my group standpoint, where I see a hesitancy to do rotational atherectomy. It's not that people won't, but there is a big hesitancy. And I see the market play out on the micro all the time. And so then it's to your other point of, all right, well, if that's not the case, will you guys do the specialty balloon at high pressure? And I get a lot of no. And I don't know, right? That's just one institution. I can't say that that's reproducible, but my gut tells me it might be. And then personally, I don't care. IVL, cutting balloon at high pressure. I know one gets reimbursed. I know that one is frankly easier to use. And I know that I've used one an awful lot and not really had a lot of complications. So
yeah,
if it's one and the same, it's just hard to move the needle on that for me. But I also don't practice in a cost-constrained environment, right? Like if I worked in an NHS, or I worked in Canada, or I worked in some places where cost is a big concern, or I had a certain bucket, and once that bucket was tapped, then we like can't take care of people, which my friends in other places talk to me about. This is a different conversation, right? It's just different depending on the market that you're in. And so I guess if I were to look at that, let's say the publication comes out and the headlines are true, that, it's all 6 one way, half a dozen the other, and, use one's cheaper and whatever, still got to implement it. And I'm having a hard time believing that I'm going to see people using cutting balloons at high pressure. Maybe I'm going to be proven wrong. I guess I find that to be a little hard to believe, but maybe. Love to see it.